Okay, so our next talk is going to be temporal bone talk, and this is I'm going to hopefully demystify the major topics here for you. I know that temporal bone is very scary to a lot of people. It's not well understood, mainly because it's not taught well. So I'm going to fix that. So let's go on with our first case here. Now, throughout this entire lecture, what I'm going to do, understanding that most people don't have a good grasp of the temporal bone anatomy, is that I'm going to show pathology with normal ones next to it. So let's go ahead and do that. So normal labeled normal. I'll give you a second to look at it. And what we're seeing is sort of this soft tissue thing here, right? And that's not there over here. So the trick is that our soft tissue finding is, well, wait for a second. Let's go to the next question. So family medicine has already ordered a biopsy before the read was in. Should we schedule that for the morning? So this is an old trick for oral boards, was anytime they ask you to biopsy something, they were trying to fail you. So normally it wouldn't come up as to whether or not you wanted to biopsy something, but they just were like, should we biopsy that? They're trying to get you to like biopsy the aorta or something. They were trying to fail you. So the answer is always no, unless you're dealing with a breast. And the answer is always yes. You should go back and look at the case and figure out the fact that it's probably a pseudoaneurysm or something like that. So this is an aberrant carotid, and you can see that it's contiguous with the horizontal portion of the carotid canal. And also notice the fact that there isn't a vertical portion. So remember, it's coming up from your neck, right? So there's a vertical portion that's drilled through the bone, and then it makes a turn and goes horizontal as it heads into the around where the cavernous sinus is, and the MCA is going to come off there, right? So if they're going to show this to you, they're going to show it contiguous with the carotid canal. I would expect that this would be the plane that it would be shown in, most likely. This would be tricky. So what do you need to know about this? One, don't biopsy it. Two, it's not even what's sort of a carotid, but it's actually a regression of the normal cervical ICA, and then you have an enlargement of a collateral vessel that happens to go through the middle ear, so that's why it ends up looking like that. So the cervical carotid is not really there anymore. Don't biopsy it. Look for it in that plane where it's contiguous with the horizontal component. All right, so next case, good chance to look, and then drop the normals in here. So normals on the bottom, abnormals on the top, and probably notice that this bone here looks like it's been chewed up, right here, and there's some soft tissue stuff here in the middle ear. Here's an MR that's post-con, and it's demonstrating that this mass is super duper avidly enhancing, right? This thing. So it's super avidly enhancing. And you just so happen to take a look in the ear, and you see a big purple thing. So this is a glomus tumor, paraganglioma, and there is a whole bunch of different vocabulary for these things, which could lend itself to extreme trickery. My interactions with academic neuroradiologists is that they get really annoyed if you don't describe it as the exact one. So I would not be surprised if they, the distractors are all glomus tumors, so you have to be able to tell them which one is which. So that sounds scary, but it's not that hard. I'm going to help you out. So let's look at them in two categories: the ones that are below the level of the jugular foramen, in other words, the ones that are in the neck, and then the ones that are above the level of the jugular foramen, in other words, the ones that are like temporal bone cases. So let's look at the neck ones first. So the one that you probably have seen the most in case conference or in case books is the so-called carotid body tumor, and that's the one that they show like on angiograms that is pushing the like it's at the jugular bulb, right, and it's at the bifurcation. It's pushing the external and internal carotid apart from each other. So it's a classic way to show that. The one that you probably have not seen, and the reason you haven't seen it is because it's, well, let's finish talking about the carotid body tumor first. So it pushes apart. This is the most common one. It's the most common one shown. It's the most common one in books because it's the easiest one to get pictures of. And they are often, well, they can be more than one. So just like aneurysms in the head can, when you see one, you're supposed to look for the next one. When you see a paraganglioma in the carotid body, you're supposed to look for the second one. That would be a good next step question. Look for the second one. Because if they're in that common spot, you're supposed to look. And then ascending pharyngeal artery, which is a branch of the external carotid, tends to, like if you're going to try to embolize something, that's where you would hit it. So the next one is the one that you probably haven't seen, and it's very vaguely seen, barely seen, because it's so rare. And that's the one that occurs sort of medial and tends to push the vessels like anterior. Well, it occurs lateral, and the displacement is anterior and medial. So it's occurring and it's pushing them anterior and medial. The thing to remember about this is that it is the least common, and it is the one you're unlikely to see, and you probably could forget about it. Just don't pick this one if it happens to be a distractor. So, let's go back to that for a second. I'm going to do something for you that's going to help you out. All right. Otherwise, because I'm a visual person, we're looking in the axial plane. So that's medial, even though it's sort of lateral off the page. This was just the cutoff of the axial plane. So remember that in your brain. Medial, anterior, and medial displacement with the thing is off to the lateral side. Okay. All right, so now we've done the stuff below the level of the jugular foramen. Let's do the stuff above the level of the jugular foramen. So these are going to be basically your T-bone lesions. So the way to distinguish between them is that the tympanicum, you can make like tympanic membrane, that is the one that's in the middle ear. In the jugulary, like jugular foramen, that's the one that's in the jugular foramen. And then there's another one that I didn't mention, but could be brought out in the form of trickery, which is, what if you have a lesion that is both in the middle ear and in the jugular foramen? Well, then it's a jugular tympanicum. They just combine both words. So let's look at a couple here. So this one here, that thing, it's in the middle ear, right? So this is the glomus tympanicum. So it's a mass. It would be enhancing if we had MR. It's right next to the cochlear promontory. So what's the cochlear promontory? This thing's the cochlear promontory. And right at the level of the smiley face, that basal turn, that is like, remember that, cochlear promontory. Another piece of trivia is Jacobson's nerve tends to be involved. All right, and now as opposed to this one, so this is at the level of the jugular, right? And you can see that there's bony destruction and so forth. Probably can see that. So all this stuff abnormal, this thing here eaten out here. So, and then if we looked at it on MR, it's enhancing. All these things are super duper vascular. You can treat them by embolizing them. This is the glomus jugulare. It's in the jugular foramen, tends to have a permeative destruction. Think about like pulsating vascular type of tumor, permeative destruction, avidly enhances, of course. So, and then here's the case that was actually the case that I showed originally, where you've got involvement in both the middle ear and at the jugular foramen, and this is our jugular tympanicum. All right, boom time. All right, next one. Let's get a normal in there. So what you probably are seeing is a big mass in the epitympanum. So, what the hell is the epitympan? I've mentioned that a couple of times. So, let's just review this real fast. I'll orient you. So, here is my finger, and I've stuck my finger in my ear because my ear is my fingernail. Here's my knuckle. And this is my finger in the ear because my ear really itches, so I'm scratching it. So, like, right here would be your TM. And so, above that, some people call this the attic. We're talking about this stuff up here. Some people will call that the attic or the epitympanum, like epi meaning above. And then like below, and then there's mesotympanum that's in the middle. M, maybe I should do it over here. All right, M in the middle, right? Fingers in the ear here. Epi is above, or the attic. And then stuff that's below that is the hypotympanum. So what we're talking about is something in the epitympanum. And this is a very classic thing. Probably have seen this before. For practical purposes, you may actually see it in the real world, even if you're a generalist. And the ENTs want to know if it's otomastoiditis, which can sort of look like soft tissue in the middle ear, versus a cholesteatoma, which is what this is. And the difference is that cholesteatomas tend to destroy the ossicles. So this is an acquired cholesteatoma. And basically what it is a bunch of skin and like keratin tissue that's all balled up there, causes inflammation, which erodes the ossicles and other various structures. So I called it acquired, which means it makes you think that there's another one that's probably congenital, just like I mentioned here. How do you tell the difference between those? Are there different names and various pieces of trickery that can be asked? Yes, of course there are. So let me break it down. The tympanic membrane, so remember, finger in the ear, just to orient you here, fingernail, crazy looking triangle finger. So there's a finger in the ear, just to orient you. And here's the TM. TM has two parts to it. It has a floppy part, the pars flaccida, and it has a tense part, the pars tensa. So just remember the floppy one is the more vulnerable one. So what you end up having is like sort of a defect that occurs there, that the vulnerable part and the flaccid part, and it gets like a vacuum effect where it gets sucked in a little bit more, and you end up with this ball of keratin tissue and stuff, like I said, that gets all stirred up. So it starts right there, and then it progresses further, which will lend to multiple choice test questions. So let's review some anatomy that's relevant. So here's the normal, and then I've got this thing highlighted here in blue. That little space has a name, and that's Prusak space. Now, why does that matter? That is where the acquired cholesteatoma begins. And you can imagine that here is our TM, can't really see it, and this was the flaccid part up here, right? So then you've got the vacuum effect, and it gets pulled in here and balled up in there, and that's where it starts. So that's why people look there first, and that's why it has a name that people care about. And then there's this thing here. So normal, and then outlined in yellow, and it's right next to that Prusak space. This is the bone that's right here, and this is the shield. Well, what's it the shield from? Well, one thing, it's a shield from my finger coming in there. Let's see, or a pencil, or whatever you were gonna like jam in your ear. So think about that as the shield, which is, in Latin apparently means scutum. Scutum is shield, and because the cholesteatoma starts here, that's the first thing that gets eroded. So the erosion occurs there first. And then now let's list the last piece of anatomic trivia. We're seeing the semicircular canal, this thing here, and the one that's pointing, so this is the ear's out here, right? So maybe we'll make it look like mine with significant cauliflower on it. But you have to earn that, by the way. You don't get that for free. And so this is the lateral part, right? Because it's pointing lateral. And so this is the lateral segment of the semicircular canal. Now, who cares? People who write multiple choice tests and squares care, so you should care. And this is why. So if you've got a cholesteatoma here, this is an axial cut, and we're in the attic, we're in the epitympanum, you can see that it's going to hit that part first, right? That's the part that it's going to be eroding first. So that's which part of the semicircular canal gets hit first? The lateral part, as the cholesteatoma is going to work its way lateral to medial into your brain. All right, so that concludes our discussion on that. All right, next case. So we've got a T1 post-con. This is another thing it's avidly enhancing. And then it's another thing here that's sort of looking permeative. That was a buzzword we used for the paraganglioma, but this is not that same location, right? It's at a different location. So location, location, location. So got the normal here. Do you remember what that thing's called? It's not this. It's that. What's that? What's that little thing right there? So that is the vestibular aqueduct. So let's do I drew that. I'm pretty proud of myself. It's in one of my books. Might be in the Case Companion. Might be in both books. Anyway, I drew that. And it's so here's your vestibular aqueduct. And if you've got your tumor right here, it's actually right at the level of this endolymph sac that's part of this whole apparatus. So that's an endolymph sac tumor, which occurs right at the vestibular aqueduct, which is right where the endolymph sac is. What do you need to know about this thing? What it enhances, and it has intratumoral calcifications, sort of like, just look, again, has that sort of moth-eaten, chewed-up looking thing. Amorphous calx. And the number one thing you need to know about it, if you remember anything other than the location, is this. VHL. So it's sort of a defining lesion of VHL. If you see that the patient has VHL, statistically, they're 30% of the time they're bilateral, just like what? Clear cell renal cell carcinomas, also with VHL, right? 15% of the time, VHL patients will have these things. They go together like peanut butter and jelly. Okay, I say endolymph sac tumor, you say VHL. I say VHL, you say endolymph sac tumor. And you also say at the vestibular aqueduct, at the endolymph sac. All right, next case. All right, so let's bring it to normal. What we are seeing is that thing. Notice how the bone here is nice and crisp and clean. We've got that little thing here. Give you another cut. Showing it again here and here. This is actually a case that I had recently. Caught this bad boy out in the wild, and take a zoom up right there. So it looks like the bone is spongy, huh? But don't expect for that name to be used. I would expect the name that doesn't make any sense to be used. Why would they name it that or use that? Because multiple choice test question, writer. The purpose of the test is not to test your knowledge, right? It's to trick you. So most of the time, it's also to get your money for the test, for variety of different things. It's a means of control, and so otosclerosis. Remember that because it makes no sense. Otospongiosis is the name that makes way more sense. Both names can be used. So what the fuck is this thing anyway? Basically, it's an idiopathic, slow, progressive cause of deafness. And you have a spectrum with mild, which is like histologic findings that you're not going to see, or maybe you're going to see on postmortem. And then it can occur sort of in a fenestral location, which is what this one is. And then as it gets worse and worse and worse and more extreme cases, you can actually end up getting a retro fenestral or cochlear otosclerosis. Most of the time, if you're given a choice, they will call it fenestral, and they'd be like, why would they call it that? I'm going to show you here in a second. So it's often bilateral. It favors white people, and it's characteristically causes this demineralization, right? Like a spongy look. It does not occur in kids. Remember I said that it's very slow growing and progressive, so you're not going to start seeing these findings until middle-aged people or later on. In the really severe cases, the stapes will actually get fused, and that, I guess you could say, is sclerotic, otosclerotic. And those people are screwed because one of the treatments is actually to replace the stapes with, they have to end up replacing the stapes with a prosthetic, which can be more difficult. All right, so moving on. All right, anatomy review time. So we're going to explain that word fenestral here. Internal auditory canal, cochlea, vestibule, posterior turns, and horizontal/lateral turn of the semicircular canal. Remember that lateral turn, that's where that cholesteatoma hits. And then this thing right there, fistula antifenestrum. That's a fancy Latin word for where this thing's at. So the fenestral subtypes are at the fistula antifenestrum, FAF. Boom. All right. Next case. Let's take a zoom up here next to a normal. So that's what we're trying to show. And basically what this is it's mineralization within the labyrinth, or ossification, labyrinthian ossificans. So labyrinthitis ossificans. Now, this is a mineralization here. It occurs secondary to inflammation or infection. So what's the classic history? Kid with meningitis. So it's almost always a kid with meningitis that ends up with this. Now, are they screwed from any particular procedure that might be used to treat deafness? Yes. So cochlear implant. This is one of the, like when you do cochlear implant workups, this is one of the things they're looking for. All right, next case. Get this normal in here. All right, so that thing. Remember that thing? I showed this thing earlier. Okay. It's not this thing. It's that thing. It's the thing behind that thing. Okay, and that is, that's your vestibular aqueduct, right? So what's different between this vestibular aqueduct and the normal vestibular aqueduct? It's too big. Well, how do you know when it's too big? The vestibular aqueduct should never be larger than the posterior semicircular canal. So let's look back at this. See this? See that? About the same size. See this? Bigger than that. That's how you know. Boom. Too big. So when you're reading these things, that should be on your search pattern, at least for younger people. And, you know, when you identify the vestibular aqueduct, make sure there's not an indolent sac tumor sitting there, and then you should look to see if it's larger than the posterior semicircular canal. So it's actually common. It's a very common cause of sensory neural hearing loss. Confusingly, the hearing loss is not present at birth. It occurs in childhood and is progressive. So just like the otospongiosis does not occur in kids, this actually does occur in kids, but it's not present at birth. So the history would not be deaf at birth. The history would be starting to get deaf in childhood, getting a workup, finding that they've got large vestibular aqueduct syndrome. So when I use the word syndrome, are there other findings? Yes, there are. The bony modiolus is absent in like 90% of the time. You can't even see that fucking thing most of the time, but it is indeed absent. So look at this. I see that thing gone, right? It's all weird looking, right? So it doesn't like have enough turns either. So it doesn't have the 2.5 turns that it's supposed to have. It only has 1.5. The vestibular aqueduct is not the only thing that's enlarged. The vestibule is enlarged also. And this is the so-called Mandini abnormality when you see all three of those together. seems obscure, but large vestibular aqueduct syndrome is actually common, and this is associated with that. So it's worth remembering. All right, so coming up on one of the last ones here. So this thing, get a normal. I actually see this all the time. It's not always symptomatic. So let's notice that, and then notice this. All right, so that right there. So what that is a dehisced superior semicircular canal. So what's the classic history in all of this? It's the... I just fall out of the chair. Noise-induced vertigo. So get a loud noise, fall over, noise-induced vertigo. So it's supposedly secondary to long-standing increased intracranial pressure. That term, noise-induced vertigo, or nystagmus, is actually referred to as Tullio's phenomenon. I love this guy. He was basically a mad scientist in the 1920s that was drilling holes in the heads of pigeons for who knows why, and he figured out that if he did it in the right spot, they could actually give him balance problems when they were exposed to loud noise. So that is the Tullio's phenomenon. Okay, next case. So let's run through these. This is a useful skill to have. So what is this? CSF is dark. Okay, so it is a T1 probably. Now, how do you know it's not flare? Because white matter should be white. So white matter is white on T1. If it's not, then it's flare. So check your CSF and then check your white matter to confirm. So what about this guy? Okay, so CSF is dark, T1. I see that he's got contrast. But what if I didn't show you that? How do you tell if people have contrast? Here's a trick. Look right here. See that? Now look right here. Boom. The nasal mucosa is a trick to tell if somebody's had contrast or not. Somebody wants to be a real asshole and they like not show you the vessels and stuff and make you figure out whether or not it's had contrast or not. Sometimes they'll show you the nose. So look for the nasal mucosa to tell if there's been enhancement or not. Okay. All right. And of course that when we do T1 post-con, just like when you do it in the abdomen, you often do with fat sat, right? So see the fat here? Notice it's satted out. All right, so that's important. And when you're walking through multiple choice questions and they've got multiple sequences of MRs, fat sat's your friend because anything that fat sats out is fat, right? So just like this fat satted out, the finding here fat satted out, it's gone. So what does that mean? It means it was fat. So this is one of the only reasons to actually do a T1 when you're looking at sort of CP angle region pathology. This is the so-called lipoma of the IAC. They're incidental. They don't mean shit. You can find them at any age. These things are actually, usually when you see them, they're midline. So either pericallosal or quadrigeminal cistern. But they are associated with stuff, especially this one. So if I show you this guy, he is associated with what? And there's a hint on this picture right here. These widely spaced racing car looking ventricles. All right, so that is agenesis of the corpus callosum, right? So corpus callosal lipomas, they're not really lipomas actually, this is a hamartoma, is associated with agenesis of the corpus callosum. All right, next case. Not going to show you normal with this one. It's too big. So this thing right here, boom, right here and here, big, what's that part of the bone here called? Petrous apex, right? The apex of the, it's eaten out right there. So big hunk of bone missing. Now here we go. So we've got T1, white matter's white, T1 post-con. Sort of can see the nasal mucosa, they're cutting off the front part there. And then T2. So we got a mass here that's both T1 and T2 bright. What's that? So there's only one thing that is this, and this is a very common thing, the cholesterol granuloma. It's the only thing that's both T1 and T2 bright. So there's a companion entity here. Same general vicinity, apex, Petrus apex, right? But this one's T1 dark, or ISO, dark ISO. And then this one's T2 bright, and it's, look at that, restricting diffusion. So you have a handful of things that you can think about that restrict diffusion, right? Hypercellular tumors, abscess, stroke, and then these things. Cholesteatomas. So you may have been thinking, well, I know that epidermoids restrict, but cholesteatoma basically is an epidermoid. It's a congenital or acquired epithelial tissue. Now, when they're in the Petrus apex, it's more congenital because it's not that pars flaccida defect thing that's sucking up in there, but it's just like that. It's a clump of tissue that's inflammatory and stirring up trouble, and it does restrict diffusion. So let's compare the cholesterol granuloma and the cholesteatoma. So CT, they look very similar. You've got that bony expansion. You can't really tell the difference between the two. T1, remember I said this is a unique feature of the cholesterol granuloma. So T1, your stick of butter, your cholesterol granuloma, T1 bright, and then it's T2 dark, or T1 dark on the cholesteatoma. T2 is not as helpful, and then the diffusion is. So this could be shown in one of two ways. They could show you they only need to show you one sequence here to make you call it that. They only need to show you one sequence here to make you call it that. So remember, cholesteatoma is basically an epidermoid, and they both restrict. Cholesterol granuloma, T1, T1 for start your morning with butter on your toast. So it's the first thing you do in the morning. T1 butter sort of looks bright. T1 bright, cholesterol granuloma. So if you can remember that, then the other one is the other one. Okay, so that is the conclusion to the T-bone talk. Next talk is a toxic metabolic talk.